So my name is Sarita Khemani. I'm one of the clinical associate professors at Stanford University. Um, my role over there is as a perioperative medicine physician. That means I take care of patients in terms of their perioperative optimization, their risk assessment for surgery, and also postoperatively try and prevent postoperative complications. And currently, I work with the neurosurgery team and help manage their patients. So, today, what I will talk a little bit about is acute delirium in the post operative setting and its profound effect that it has on the medical health of the patients, not only short term, but long term too, the public health impact of this condition, and how at this point we are at a place where we can do personalized management and offer personalized care for these patients. Um, so I will just start a couple of slides with a case that I just saw, and we see these quite frequently. But this patient, who was 60-year-old male with history of hypertension, diabetes, and hyperlipidemia, he was admitted for lumbar surgery for fusion of his L3 and L5. So patient underwent surgery on day 0 and did quite well. He was okay the next day, but then on day 2, he had a sudden change in mental status, marked with confusion and agitation. He had assessment by the nurses who used the CAM score, which is the Confusion Assessment Method score, and he was diagnosed with delirium on day 3. At that point, because of his agitation and confusion, was hard to control, so he was treated with antipsychotics, Haldol, and he was also given other medications. And then he was watched for the next few days. He did become less agitated, less, better oriented. And then by day 6, he did have improvement in his mental status, and then he was discharged on day 7. So what you will notice here is that, this is his course for his delirium. And when he did come back, and when we say he got better, he really never went to his baseline. So we think that, okay, he's not agitated, he's oriented now, he is back to his baseline, but he's not. And that's what we are learning more and more about acute delirium being a much bigger problem than we had thought earlier. So the other thing is that we had thought that he would get discharged by day 4, but as you can see, he was there until day 7, which definitely adds many other issues. So we have a great opportunity, and we have a lot of current research and in biomarkers that can be done to help with better management. So in this patient, let's take this patient. So there was no history of cognitive impairment. So he could not be flagged as someone at high risk for postoperative delirium in his preoperative evaluation. We didn't know whether he was experiencing clinically silent neurodegenerative changes before surgery, and they were not identified. And had we identified any of those, we would have had better steps. And he would have been observed much more carefully, and then certain changes during anesthesia and postoperative care can be made to prevent delirium. So we do have a great opportunity, especially in the preoperative period, to identify these patients. So just this slide for, just in case anybody was wondering what is acute delirium. So it is a complex multifactorial neurocognitive disorder. It's acutely starts, and that's the hallmark of it, which differentiates it from dementia, which is it is acute onset. For postoperative, of course, it starts in the postoperative period, and then it's fluctuating. So there are times the patient seems okay, but then there are times they are confused and they are disoriented. So it has a fluctuating course. Confusion, inattention is part of it. Sometimes they're agitated, and depending on the type of delirium, they can be inactive. And they have altered perception. Altered perception, which leads to delusions, which leads to hallucinations, leading to significant distress for both patients and their caregivers, and for the care team. So it is different than dementia and other cognitive disorders. Although there are patients who can have both delirium and dementia happening at the same time. It's purely a clinical diagnosis with no additional data for the clinicians to guide the diagnosis at this time. So, and because it's heterogeneous, it presents widely differently in different patients. So that's where the opportunity is to try and get additional data to help with this. There's no effective treatment for delirium, so the best course is prevention. So impact of post-operative delirium. So annual healthcare cost in US of delirium is upwards of 182 billion per year. So that's the delirium as such in all the areas, but in post-operative it accounts to about 44 billion. So pretty significant. And right now, more and more patients over 65 are undergoing procedures, and that will keep increasing. So patients over 65 represent more than 40% of the surgeries that they're undergoing. And they are, say, 17% of the population, which is supposed to increase to 25% by 2050. And the incidence of post-operative delirium is anywhere from 15 to 53%. Depends if the patient is, over 80, the incidence is almost close to 50%. And if they're over 60, the incidence is around 30%. So it's something that will continue to increase as more and more of our patients undergo surgery. And we've seen that in our practice. We do surgeries in 80 and 90-year-old patients are undergoing surgeries frequently. So what is the medical health impact? Of course, it's something that increases. It's actually the most common complication that we see post-operatively in patients over 65 years old. So prevalence in terms of, as we already discussed, can be anywhere from 30 to 50% in over 65. It is associated with 2 to 3-fold increase in mortality rates during hospitalization. And studies have shown that the 36-month mortality rate is around 29% as compared to 9% for somebody who did not have delirium. So it does increase significantly. And another study had shown about almost 50% 5-year mortality in patients who have delirium. So it does have significant morbidity and mortality effect. What about the length of stay? Like our patient who went from 4 days to 7 days because of delirium, it increases the length of stay about 1.5 times longer than that of non-delirium patients. Which definitely, of course, increases the healthcare cost. And then being discharged to a facility, like a skilled nursing facility or acute rehab, also increases significantly, about 1.5% instead of them going home. And the readmission rate is up about 2.3% for these patients. So it does affect, it's just not a 2 or 3 day thing. The effect of delirium in the hospital carries on in many, many ways. And the biggest thing that we now have found in the more recent research is that the long-term effect. Initially, the thought was that you have this episode of delirium, it's because of surgery, it's because of all the opioids, and now you're better and you're done. Like an infection, like you had pneumonia or you had UTI, you got antibiotics and you're done. But that's not the case. And that is the most worrisome part of this. What we have now recognized is that there is what is called perioperative neurocognitive disorders. So it's not just a one episode. So in these disorders, we start with preoperative cognitive impairment. So somebody who could come with pre-op cognitive impairment, then they have post-operative delirium, and then they're discharged. But like our patient, they never go back to baseline, and they're impaired for the first 30 days, which is the delayed recovery. But unfortunately, many of them continue to have neurocognitive disorder up to a year and beyond. And that is the worrisome part, that this is not one thing. And that is something that is still not identified or followed up in many, many cases where we don't know what has happened and nobody goes back to it. And the reason is, like our patient who left and seemed okay. So we're like, okay, the patient is better, let's go. But the patient is not better, because now for 1 year or longer or forever, the patient continues to have these subtle changes in cognitive function. And those might not be clear to a physician or a clinician or family members who just see them, outwards, but affecting the memory, executive function, processing speed, other abilities gets affected, even if it's subtle. And that, as the time goes on, affects a patient's quality of life, their independence, and engaging in social activities, which will further affect their cognitive function and cause deterioration. So this was the JAMA Neurology, published in JAMA Neurology, and that showed actually the effect of cognitive outcomes in patients who had delirium, both surgical and non-surgical patients. And it showed significant association with cognitive impairment 3 months or longer after the delirium episode. This was the one that was done in JAMA Psychiatry that looked at again, the cognitive decline in late life due to delirium. And what they was a different finding was that when you look at these are the patients, and the patients who had the most decline going forward, of course, were the patients who had episode of delirium and who had the most dementia pathologic burden. That had the highest decline. And the least was patients who had the least dementia pathologic burden and no delirium. So from what it was suggested that the delirium in the presence of dementia-related neuropathological processes was associated with cognitive decline beyond what you see with the neuropathological process. So it wasn't that, delirium just along with the pathological decline in dementia happened. It had additional effect, and that's what we would like to prevent. So, and again, similarly, there are studies that have actually looked at the CSF after delirium episodes and found changes similar to Alzheimer's in terms of the tau and the amyloid beta levels, and then even decrease in the cortical and hippocampal gray matter after the episode of delirium. So there are changes significantly that could affect that happen. And another theory, as we know, the cholinergic deficiency hypothesis, that delirium is linked to substances that impair cholinergic function. So we avoid anticholinergic substances, medications in the hospital post-operatively unless we have to, because definitely we have seen that it worsens their delirium and not only worsens, causes them to have delirium and worsens the symptoms. So there is a clear connection between cholinergic dysfunction and severity of delirium symptoms. Now, for Alzheimer's too, it is characterized by a central cholinergic deficiency. So the degeneration of cholinergic neurons is noted in pathology of Alzheimer's. And so it is possible that they may represent delirium and Alzheimer's may represent different points on a continuum of the cognitive disorders rather than entirely distinct conditions. Public health impact, as you know, we're looking at all these numbers, it has emerged as a marker of quality of care. So there are a number of quality improvement initiatives that have been implemented to try and improve this, but I think we need more. It is definitely patient safety and public health priority, especially with the increasing number of patients undergoing surgery, increasing risk of neurocognitive disorder, poor functional status, and increased burden on caregiving and healthcare system. Our group had started perioperative management of patients at Stanford, and we've been there for about a little over 10 years. And so our group actually created a protocol, and this was a task force that was headed by my colleague, Dr. Hodge, to create a protocol to help with prevention and early detection. So as part of the protocol, the nurses were taught. The nurses were first taught to screen all patients for the presence or absence of delirium. And we used the CAM score, which is a confusion assessment method score. And then nurses additionally screened all patients for risk of delirium. So the screening was done, and then we also helped create a physician order set for delirium. That was followed. So once the patient was screened as a higher risk for delirium, there was an order set that a physician could click on, and it laid out all the steps that can be done in terms of non-pharmacological steps and then pharmacological things that can be done to improve that. So this was studied for about 5 years, and then what we looked at it was that the data that showed was, of course, with the education of the clinicians and the follow-up and the creation of the protocol, we did see that there was some good results. So the delirium decreased by 25% per year among the high-risk patients. And there was a slight decrease in the length of stay. There was definitely improvement in the mortality by 16%. And also the discharge to nursing homes was decreased by about 17%. So I think this was great, and it's still in use, and we use it. But at this point, we are thinking that we need a little bit additional support and data. So this is all done by clinicians. Depends on the clinician's knowledge, and it can be variable. And so what we need is we need to have things like an additional data like biomarkers along with the clinician's assessment to help with the early detection and prevention and long-term follow-up. So so in terms of where can we really help in terms of changing things? So we know that prevention for delirium is the best step, and for that we need to identify what are the risk factors. So it really falls into three categories. We have the patient-specific risk factors, we have the anesthesia and surgery-specific risk factors, and of course the post-operative care that we provide. And for the patient-specific, older age is actually the biggest problem, and of course that as we do more on patients, it will definitely be affecting that. Then the ASA score, and then the comorbidities, the number of comorbidities they have, and then of course their many mental score. So having any cognitive impairment before surgery does increase the risk. There are certain things for surgery and that we cannot change, like anatomical site and length of surgery, although length of surgery is improving with improving techniques. But the kind of anesthesia, the depth of anesthesia, invasiveness, and hemodynamic stability and can be looked at. So that's something that is being already worked on. Post-operative, the biggest thing at this point is the opioids that affect. and to try and do multimodal analgesia is the main treatment method that we use. Of course, there are other issues that we need to prevent, like urinary retention, constipation, taking the lines out as soon as possible. Okay. So this is really early on in research, but we are really hoping that we would get more advanced in this area. And then there is promise of integrating biomarkers as tools for assessing the risk early on. So finding out what is the risk, then what is this type of delirium, whether it's active or subacute, what is the short and long-term effect, and which treatment probably be the best for that particular patient. And that's where precision medicine does have a role. It's just in the really early stages, and it's something that will come and help our patients. Now, and the reason is that we can use certain indicators because there are many factors such as surgery. In this case, in our case, it's a surgical trauma that causes endothelial damage, and that increases the blood-brain barrier permeability, allowing the immune cells, the cytokines, and other neuroinflammatory products to penetrate the brain parenchyma. So once they're there, they actually activate the microglia, leading to neuronal dysfunction, mitochondrial dysfunction, and dysregulation of BDNF. So it is now clear that it's the inflammation that is playing a huge role around the perioperative period. So as you can see in this picture, how it's leading to systemic inflammation, and that can cause the neuroinflammation too. So in terms of the markers for delirium, so how would that work? And I think what we can use is markers in every aspect, and then bring them together to find the right treatment, right prevention, and the right treatment. So the risk markers can start with, of course, preoperative. Now, preoperative period is a great time because we are doing our patients' evaluations anyways, and if we can add some other things to that, which helps us, and we know the patient even before they come to the hospital, will be hugely effective. So, for example, our patient did not have any history of cognitive impairment or was never diagnosed. Maybe the patient had cognitive impairment. But so in doing preoperatively assessment in terms of, and I know this is improving still, but I think we will reach a point where we do evaluations of cognitive function more with biomarkers, with beta amyloid, phospholipid tau, and neurofilament light chains, so that pre-op we know that this patient does seem to have mild cognitive impairment and will be at high risk for delirium. As we discussed, the inflammation can be a huge problem, and so can there be inflammatory markers that can be used to prevent, because there are certain individuals who are predisposed to an exaggerated inflammatory response in the setting of acute physiological stress like surgery. So if we know that this patient does have an exaggerated response, by measuring certain markers, then we can actually be more effective in treatment or just close observation. Markers of damage, I know, are still being studied, but that is again something that will help us if the patient does develop delirium during and after, and for ongoing follow-up of the patient after their discharge. And of course, the combination of these will be used. So what I feel is that, at this point, for us, for the last decade, we have anyone who had a heart attack after surgery is now discharged with a great follow-up care, with follow-up with a cardiologist, testing, just because we want to make sure that this wasn't just one-time thing. And what we need the same thing for acute delirium, where we have a close cognitive follow-up by an expert, by a noticed so that these conditions don't get missed. Thank you. I'll stop sharing.
Thank you for the wonderful. Okay, I would like to have a question with you.
Mhm.
So, how different is delirium with Alzheimer's disease?
Yes, so it's actually, again, it's very different in terms of its presentation. So the clinical presentation is very different, right? So Alzheimer's is a very slow process that happens over the years. So the changes in our brain happen over the years, and the symptoms also appear really slow. That's why they are missed initially. Whereas delirium is an acute process. You will see the difference right away, and it usually happens after an insult like surgery or infection or other kind of traumas that we experience. And so that's the big difference. And the other big difference between the delirium and dementia is that it's uh, delirium is a fluctuating. So when we see our patients, it's sometimes they seem better, and then if you go a few hours later, they would be confused and they would be disoriented. Whereas in Alzheimer's, it's a steady decline, which is really slow, but it doesn't go really in a waxing and waning manner. So those are, I would say, the two big differences in terms of clinical picture. And in terms of the pathology, as we know, Alzheimer's, they can have similarities, but the pathologies can be a little different, although we are learning more and more about delirium and understanding that they're not completely different. There is an overlap.
Okay, great. And what are the prescribed biomarkers currently in use for delirium?
Yeah, so that's where we are, and I'm hoping that everyone here is maybe working on it, because we actually don't use any biomarkers right now. There are no biomarkers that have been really in practice for use in delirium, and that's where our push is. That we now that the biomarkers for Alzheimer's and the mild cognitive impairment are being uh, studied more and are being used a little more, can we take those biomarkers and help in studying our preoperative? So I think we can definitely, there's a huge place for using the biomarkers for Alzheimer's in a preoperative setting to find out if somebody who's coming for surgery has any cognitive impairment. So we are really hoping that we can start using them before, but the biomarkers for inflammation and stuff right now are non-specific, and we need to have better ones.
That's great. I really see a very potential on your project and really impress you on the work you have done. We congratulate you for once again for your wonderful work. Thank you so much for your valuable presentation.
Thank you.